You hear me?
Yes, we can hear you.
Yes, we can
Okay.
hear you.
All right. Okay. Good afternoon, everyone. Dr. Jula. I'm a pediatric surgery registrar at FRE in Walter Sisulu in East London complex. Today, I'm going to be talking about the posterior urethric valves. So these are the subheadings that I'm going to cover: the pathophysiology, clinical presentation, investigation, initial management, and endoscopic management. We won't go further to further surgical management and management of the complications in this discussion.
So, Andile, you will need to just go a little bit close to your mic and talk a
Okay.
little bit slowly and loudly. Thank you.
All right. Okay.
Okay.
No, thanks. Okay. All right. So these posterior urethric valves, which thought to be a congenital malformation in males. So this is just a schematic representation of a male lower urinary system, which shows a bladder, then you have a bladder neck there, then the prostate, and it shows the valves, the posterior urethric valves on the posterior urethra as just thick membranous leaflets that tend to meet in the midline, just below the urethral, just above the urethral sphincter. So as I mentioned, that there are congenital male malformation of a hypertrophied variant of inferior urethric crest. They are thought to be the remnant of mesonephric duct. So it's these leaflets that come to fuse in the midline and they cause obstruction in that way, just proximal to the external sphincter. So this is a representation of the types that were first described by Young and as type 1, type 2, and type 3. When looking at what you saw in type 1, basically the two leaflets that when they fuse, they sort of form like a dome shape form of obstruction. So as the urine is coming from the bladder tracking down, it kind of get caught in these leaflets that are divided by these fibrous tissues where they meet. And actually type 2 is formed in an opposite way, that actually the leaflets are actually facing down where they meet, and it's actually non-obstructive. Type 2 because of the way that the leaflets of the valves are fused. And type 3 is thought to be just circumferential membrane, which forms like a diaphragm that has got a central opening. And also it does cause, and also this type 3, is also an obstructive type. So there's actually a lot of different anatomical variation in this obstructive type that they actually have been grouped as called COPAM, which is a congenital obstructive posterior urethral valve membrane. And this excludes type 2 since it is not obstructive. So PV are the commonest cause of congenital obstruction on the lower urinary tract, and they comprise about 10% of antenatally diagnosed uropathy. And the incident are estimated to be about 1 in between 5,000 to 8,000 male birth. but it is thought to be more common for fetal death. So if you do autopsies on those fetus that died with no apparent reason, or it can be discovered that some of them, they might have had a posterior urethric valve. The severity, it varies from mild to very severe, and it can be lethal as well. And they can be diagnosed antenatally, and about a third of these patients, they will grow up and they will develop end-stage renal disease, and they might need renal transplant at a later stage. So this is just looking at the pathophysiology of the condition. So in utero, if there is a significant obstruction that result in a significant reduction of the amniotic fluid, and with significant oligohydramnios, you may end up with lung hyperplasia that is that you can see on this X-ray, as well as in severe cases they can have Porter's syndrome. But on the urinary tract system itself, you get injuries from lower down to up to the upper urinary tract system. So you get this thickened wall bladder that is trabeculated, and you get with the backflow of the pressure, you get hydroureters, and that also extend into hydronephrosis as well with the pressure. So this is also just another representation of the sequelae of posterior urethric valves. Shows that there is an obstruction, which is can be caused by copum, any of the component of copum, and without any urinary drainage, you get dilated posterior urethra, dilated, hypertrophic bladder, and then with the backflow and the back pressure, you get hydronephrosis and hydroureters, which also affect the functions of the kidneys. So clinical presentation. So it can present at any time. They can present antenatally as neonates, infants, toddler, and school age, or even in the adults. Posterior urethric valves have been diagnosed. In utero, it's usually by form of ultrasound, where if you pick up oligohydramnios with hydronephrosis, or you might be able to see also some bladder and some bladder changes also on the ultrasound that also can be diagnostic. So how do neonates, different ages present? So neonates, they can present as just urinary retention, or they tell you that the patient hasn't passed urine for the whole day after birth and has a bit of unhappy, irritable. They can have respiratory distress if they have lung hyperplasia, or in worse cases, they can have also ascites as well, which would be your urine ascites. Infants, they will present with urosepsis, which is also is just irritable kids with high fevers. They might also have feeding intolerance during that time. You might pick up that they have failure to thrive, some electrolyte imbalances as well as dehydration. Toddlers, they tend to present more with urinary tract infection. They can have incontinence or just voiding dysfunction. They can have dribbling after voiding, or not completely voiding of the bladder. The older children, they present also with recurrent UTI, and they can have nocturnal enuresis, also with abdominal distension, which will be associated with complication like hydronephrosis as well. So in these cases, there aren't too many differential but diseases like Prader-Willi syndrome, urethral atresia, and bilateral high-grade vesico-urethric reflux as well, they can sort of give you this presentation. So looking at our investigation measures, so the gold standard is the MCUG, which is a maturing cystourethrogram, and we have ultrasound as well. Cystoscopy can be diagnostic and therapeutic as well. And we also need to check the electrolytes, and we have nuclear medicine. Fetal MRI also has been described for difficult cases in utero. So this is a representation of an MCU gene, which was done for a child with a posterior etheric valve, which shows a full bladder with a hypertrophic bladder neck and this dilated posterior urethra. And just below that, you can just imagine that the point of obstruction where the valves are. In other cases, you are able to appreciate a sharp, well-defined lucency around this area of obstruction. And this description can be described also as a keyhole sign with this anatomical representation of the bladder and the dilated posterior urethra. So as part of the disease, you can get hydronephrosis and hydroureters. You can see here, there's quite impressive hydroureter, which you can see on the side, it goes on to the kidney, and you have your hydronephrosis as well. Whereas on the left side, it's not as bad as you can appreciate on the right. So this the ultrasound investigation. So you will be able to appreciate the abnormal echogenicity and cortical cysts, which signify that there is the severity of the condition, and the lack of cortical and medullary differentiation as well. It's also a sign of a severe form of the disease. Hydronephrosis, also you can pick it up on ultrasound hydroureters. You can still also be able to see posterior urethra if you look for it as well. In utero, there's ultrasound representation here also, which show keyhole sign in an ultrasound. This is a ultrasound that was done in utero. You can see a dilated urinary bladder with a dilated and elongated posterior urethra as well. And then on this side, you can see this is a dilated bladder full of urine. And on the left side, it's a left ureter, which is also dilated, because you shouldn't be able to see a ureter like this in on the ultrasound. So further investigations. So the fetal MRI, which is useful in the antenatal cases, but it's not something that is done often. And you have to do the electrolytes, because these kids, they present with metabolic acidosis, they have hypocalcemia as well as a hyperkalemia. Your nuclear medicine scans are good for assessing differential in function, and they can also look at the anatomical parenchyma of the actual renal tissue as well. Cystoscopy, as I mentioned, it can be diagnostic and as well as therapeutics, because you are able to actually visualize the valves, and you can do some procedures through the cystoscopy to treat these posterior ureteric valves. So looking at the initial management, it will involve managing the respiration if there is a respiratory distress, maybe secondary to pulmonary hyperplasia, and if they require ventilation, then they would need to be ventilated. But the mainstay is also to drain the urine, whichever way possible. You can pass in a catheter, urinary catheter for the drainage. And if that isn't happening, then you can look at the alternative ways of draining the urine, because the main thing is you have to open the drainage of the urine, and you have to rehydrate the baby and correct the electrolytes, monitor the creatinine, and treat sepsis with antibiotics. If ascites are present, they will also need to be drained. So surgical management, the primary treatment will be ablation of the valves. But sometimes that's not possible, and then you will have to do a cutaneous vesicostomy. Or in other cases where you're gonna have to do your supra vesical diversions, which could be either your ureterostomies. There's also a nephrostomies can be done, and there's also the procedure described sober NT uterostomy, which also is described, that can be used, which doesn't totally disrupt the flow of urine into the bladder on that side. It sort of create like a venting stoma for the urine drainage as well. So with the surgical management, at the later stage, the patient might need then a bladder augmentation as a management of their complications. So the procedure for ablation of the posterior ureteric valves, you need pediatric cystoscopy. The idea is that the valve has to be disrupted in 3 identified area at 5 o'clock, 7 o'clock, and 12 o'clock. And these are the instruments that you can use. You can use a diathermy hook or a cold knife. The idea is just to pass through the opening, and you just cut on, you try to cut on at 5 o'clock, 7 o'clock, and 12 o'clock, and hopefully that will relieve the obstruction. But there's also other options of laser ablations that have been described, which are actually can be done even with the smaller scopes. So this procedure of before you take the child for valve ablation, you have to make sure that it's well resuscitated child, and then you're gonna need a cystoscopy. Then you're gonna have to incise, as I mentioned, at 5 o'clock, 7 o'clock, and at 12 o'clock. And once that it's done, you can even check the urine stream by pressing on the suprapubic of and pressing the bladder to see if after ablation, the stream of urine improves. But the main thing of seeing if you have done it enough is it will be an MCUG that some people say it can vary. You can do it between any time between 2 to 4 weeks after ablation to see if there was a complete excision of the valves. Complications associated with the procedure, you can have incomplete valve incision, and you can also cause urethral stricture, especially with using of the diathermy, or if you are overzealous with your cutting. So cutaneous vesicostomy. So this is more appropriate in small or premature neonate when the scope size that you have cannot be used in that neonates because of the small caliber of their urethra. So doing a vesicostomy can buy you time and to drain the urine while making sure that they grow until you are able to do the ablation of the valves. But cutaneous vesicostomy also offers an option of retrograde ablation, so which the scope can be passed through the vesicostomy to ablate the valves. And it is also reversible. Once the ablation is done, it can be reversed, and it does allow adequate urine drainage in most cases. So looking at the prognostic factors of this condition, so you have favorable and unfavorable features. So children that have low serum creatinine after ablation or diversion of the urine, that's a good feature. They actually have good prognosis. Or those that you can visualize good cortical medullary differentiation, or if they don't develop vesicourethric valves. Unfavorable features involve bilateral vesicular reflux and renal cyst or poor cortical medullary differentiation, or if they fail to achieve diurnal continence by the time that they are school age. So the follow-up for these patients, follow-up is very important for these patients. You can follow them up with an MCG just to assess the condition, if it's deteriorating or getting better, because doing the primary procedure doesn't guarantee that the patient is cured. The patient can still go into end-stage renal disease with adequate primary management. So they need a very close follow-up with MCUG, ultrasound. You check for their renal function and electrolytes and their blood pressure as well, because it can be the sign of also renal failure. These kids, they also have a problem of growth. So you have to monitor them if their growth throughout the years, if they are keeping up with their normal growth. So in summary, posterior urethral valves are common obstructive uropathy in boys, and they can be diagnosed in utero. And the in utero fetal intervention is available, but with a questionable success, weighing the risk and the benefits as well. The symptoms, they range from mild to severe or can be fatal as well. So as we mentioned, a third of these patients will develop end-stage renal disease and may require renal transplant, which is also, the renal transplant gets complicated by the fact that they usually don't have healthy bladders. So long life follow-up is advised for this patient. That's going to be the end of my presentation. These are my references. Thank you.
Swandile, that was a really excellent presentation. You stuck to the time, 25 minutes, and you just showed very nice understanding, and you put it very nicely and simply. Um, I just welcome Professor John Lazarus. Unfortunately, he couldn't join us from the beginning. Um, Zwandile?
Yes. Yes,
Yes.
Prof.
No, leave your presentation
Okay.
on. Don't take it off. Just leave it
Okay. Yes.
on the screen. Yeah.
Okay.
And so uh, most of us know Professor John Lazarus. Just for those who do not know him, he is the professor and head of entire division of urology at University of Cape Town, which includes Prognostic Hospital and Red Cross Children's Hospital. And obviously, his special interest is pediatric urology. And he is the current secretary of the College of Urologists of South Africa as well. So what I will do is, if I may request Dr. Majola to make some comments first, and then we will invite Professor John Lazarus to give his advice about posterior urethral valves in general and what he does, and yeah, what points of practical importance he can tell us. So, Dr. Majola.
Hi, everyone. Am I loud enough?
Yes, yes, very good. Thank you.
Okay. Good presentation, Mzwa. So basically, posterior urethral valve is one of those conditions that are also sort of agent or emergent in getting on top of, as Mzwa had stated. And we have moved away from the term posterior urethral valves, and we've moved more towards the term COPAM, which is congenital obstructive posterior urethral membrane, which, yeah, Mzwa, you made, you reference valves somewhere in that term, which is not there anymore. So basically, you need to get on top of it. As I said, it's an urgent or emergency per se, because these kids, if you don't sort out the obstruction, they're gonna have detrimental outcomes when it comes to kidney injury and basically the child themselves. The only issue is that as well, with these kids already having this problem in utero, you don't really know how much damage has occurred onto the kidneys, and hence, even with good management of these kids, a third of them will end up having end-stage renal disease and might need a transplant. So it's important to drain the urine, as Mzwa said, with some form of catheter, transurethral catheter. If you don't have a small enough size, use a feeding tube. Drain the urine, resuscitate the child well, and then sort out the issue at hand. Firstly, diagnosis with an MCUG, as I said, that's the gold standard. And then if you have the means, then you can scope them and ablate the valves. If you can't, and because of you don't have a small enough scope, or you don't have the tools to do it, then a vesicostomy in the interim to make sure that the child is draining urine adequately so that they don't suffer from severe adverse events of obstruction and also getting urosepsis, and then sorting out the problem. That will be my comment.
Thank you, Kululeko. That was a very nice summary of the advice. I'll just like to just mention one or two very small minor things. One is Zwandile. Just remember, in addition to back pressure changes, this urinary system is dysplastic right from the beginning because things didn't start right. So the entire urinary system is dysplastic, and that's the reason why they have many of them have such bilateral severe vesico-ureteric reflux. Part of it could be vesico-ureteric junction obstruction because of thick-walled hypertrophied bladder, but many of them it would be just the dysplastic kidneys and the ureters which are laterally displaced or the opening, and so overall dysplasia. And the prognosis actually depends on the amount of dysplasia or the degree of dysplasia, and obviously, as Dr. Majola also mentioned, the length for which the obstruction persists, and obviously also on the severity of obstruction, because Vandile, you clarified it nicely that each and every child may not have severe obstruction. So it's a spectrum of disorders. Some children may present only quite late, and some of them may just be born dead. So that's that. And just for any junior doctor, don't think that catheterizing a newborn baby with posterior urethral valves is an easy exercise. Quite often, the posterior urethra is so dilated and elongated that it's not easy to catheterize the bladder of these children. So, most important thing is plenty of lubrication and be as gentle as possible. Do not force the catheter through the urethra of a baby boy, because if you are forcing, you are more likely to do damage than actual good. So if you can't do it, get your senior, and let the senior try with more expertise. So I think that's really all I would like to say at this stage. And I would then invite Professor John Lazarus. So John, I know you missed more than half the presentation, but we would really like to know your sort of current strategy. What do you do, and yeah, your overall advice about posterior urethral valves in children. Thank you, John.
Professor Chitnis, thank you very much for the warm invitation, and apologies to Dr. Jula for missing a little bit of the talk. Melinda, I can perhaps add most value by discussing some of the surgical techniques, because I think there is a little bit of a learning curve in terms of doing the valve ablation. So if you're happy for me to talk a little bit about that at the start.
No, please, no, that would be excellent. Thank you.
Good.
So do you have any PowerPoint, John, or you would just stop?
I'll just talk. You can see me okay?
No, we can see you. We can hear you. Thank you.
Oh, good.
Yeah.
So I think the first thing is that it's important not to take a child to theatre without an MCUG. That's the hallmark of the diagnosis. And, you know, sometimes people don't like doing MCUGs in babies, but it's an essential part of the diagnosis. To my mind, they once showed in a study various posterior urethras to experienced pediatric urologists, and many of them were fooled into thinking these were posterior urethral valves. So don't call it on cystoscope. You must rely on MCUG to help make the diagnosis. The technique that I would encourage you to do is, first of all, make sure you got the right equipment. We shouldn't in this day and age be doing vesicostomies because we haven't got the right equipment. And forgive me for using the name Storts, but they're the ones that we have access to. And we use the 11 French resectoscope. And we've also got access to a 10 French optical. You'll find the smaller babies, you're not going to be able to get the 11 in, and you're going to rely on the cold knife of the 10 French optical in smaller babies. So ideally, you would like to have both of those bits of equipment available. The second thing is that you're going to want to have good visualization. In order to do that, you're going to have good flow. And what I do is put a gelco into the baby's bladder that optimizes drainage out of the bladder. The second thing is that, Dr. Jula, you mentioned that you would always ablate the valve and then bring the child back for an MCUG. And if the MCUG looks good, you'd be happy. We've stopped doing that. It's not a bad thing to do. In fact, it's often quite encouraging because you can see how plastic the bladder is. It looks terrible. Christmas tree, sacculated, trabeculated, small capacity bladder with reflux, and you ablate the valve and it looks much better. But we've learned from Paddy Dewan, and Kuleko mentioned COPEM. Paddy Dewan from Melbourne, Australia, is the person who defined that term. It's probably a better term by a long straw. And he has also recommended doing a redo valve ablation. So what we do now is after 6 weeks after the ablation, we take the child back, because invariably, perhaps there's been a bit of bleeding and you haven't appreciated the valve entirely. And you often find at your second relook, there's actually still some tissue left. So we mandate these kids to go at least twice to theatre to satisfactorily assure ourselves that we've ablated the valve sufficiently. On the second look, I would also contemplate doing a bladder neck incision. There's a very good paper from Iran, which has randomized kids to either having a bladder neck incision or just having the valve ablated. And you'll know from looking at MCUGs that there's often bladder neck hypertrophy, which can be involved in causing bladder outlet obstruction. And they were able to show that they improved urodynamic features if you ablated the bladder neck as well. I don't do it in all kids, but if I found the ultrasound looking bad at the second relook, I would contemplate doing a bladder neck incision. The other thing to mention is that once I've done the ablation, I would take the scope out and I push on the baby's bladder and try and convince myself that the pressure is improved from when I pressed on it at the beginning before I'd started. And I find that quite helpful, a Creed maneuver, just to see you've got good, nice, low pressure flow out of the bladder. What else can I tell you? The other thing is that we often think in surgery that less is often more, but I want to encourage you to be quite aggressive in your bladder, in your ablation of the valve. You've really got to work hard to open up a nice channel. And it's one place that I've discovered that more is more, in fact. And I'd encourage you to try and be quite aggressive in ablating the valve to the best of your ability and proving with a Creed that you've got a good flow at the end of it. So those are the bits of techniques that I found quite helpful. I can perhaps stop there and take any questions or see if people disagree or agree.
John, thank you. Just so very interesting, because this is exactly what we had learned from Larry G. And I'm sure Professor Colin Lazarus had also learned this from Larry G when he was training at Red Cross. So we always used and still use MCUG as the gold standard for diagnosis. And I will fully concur with you, because few times we have convinced ourselves on cystoscopy for a child to have valves, but if we went back and did the MCUG, then there was obviously absolutely no obstruction. So I think that is a very important advice. And we have been doing Czechoscopy about 6 weeks after the initial ablation. Yeah, I think more is more. Is something new I have learned today from you, which is very important. But I think for occasional pediatric urologists like myself, we were always a bit scared to ablate more and cause damage to the urethra and cause a potential stricture. So I can just give example of Dr. Simango, who was our long-term colleague here in East London. And the two of us quite often did these things together. And we would do as much as we would think safe at the first sitting. But 6 weeks later, we needed to do little more in quite a few of the children. And we were forced to do vesicostomies for quite a while, because we did not have small enough instruments, the scopes. But we are blessed that quite recently our trust sponsored the smallest resectoscope, and especially it was motivated by Dr. Majola after he came back from fellowship with you. And I don't think we have needed to send any patient to you, or we have needed to do a vesicostomy in the recent time. And just coming back to the incidence, Zwandile, it's important that it is not that uncommon. It is 1 in 5 to 8,000 boys. So if we say boys and girls about 50-50, so in all children, it's about just half the incidence of anorectal malformation. But many of them obviously are undiagnosed. As you correctly said, some of the fetuses just are born dead, and a lot of children just die undiagnosed. So I think that is important for us to teach our pediatric colleagues and also general practitioners and doctors at peripheral hospital about these varied presentations of posterior urethral valves. So those are my comments. And then I would just encourage Zandile to ask questions to either Dr. Majola or to Prof. John, and others also to ask questions or make comments. Please, Zandile.
Hi, good evening, Prof. John, and thanks for your advice. I will just want to ask the question about the bladder neck incision, because I also have find out that it does also increases the chances of incontinence. And as you mentioned that you don't do in all the patients and you assess and pick the patients that are best for the bladder neck incision. So in terms of the percentage of the patients that you do, how often do you have to do a bladder neck incision, and how often do you deal with the complication of having incised the bladder neck?
Yes, I would say in about a third of cases. And you are correct that I have seen incontinence following that, but you never know, is that incontinence due to what you've done, or is it due to the fact that the child now has a valve bladder syndrome, which I'm sure you spoke about. I didn't hear that, but that's an important concept of this being a lifelong disease in many ways, and they all end up with some degree of valve bladder syndrome, which may make them incontinent for other reasons. So I think the data is pretty compelling. Our pediatric surgery colleagues in Iran have put together a well-conducted trial, and they were able to show better urodynamic features. I'll be happy to send the paper to look it out. But I think the point is that, yes, maybe incontinence might be increased, but you've also got to think you're dealing with very high-risk situation here. If you fail to disobstruct this child, they're going to go into end-stage renal disease, and they're probably not going to be lucky enough to receive a transplant. We've looked at our valve cases. We had, I think, close to 100, and we noted that if their nadir creatinine, the lowest creatinine that they got to in the first year was more than 80, they were going to end up in this end-stage renal disease. So the stakes are pretty high here, and that's why I think you've got to work quite hard to know whether your very minor surgical input is going to be effective enough to optimize this child's chance of nice low pressure bladder to protect the kidneys.
Yes, thank you, John. I think whenever you get a chance, no rush. If you can just forward that Iranian paper to me, I will share it with all our colleagues here in East London. And before I invite Dr. Majola once again, Dr. Jula has studied the problem, the issue of valve bladder. He has actually a couple of slides. So Zandile, can you share those 2 slides of valve bladder and talk about it briefly, please? Zandile?
I actually have taken them out on this presentation, those 2 slides.
Oh, you have taken them out. You didn't leave them
Yes.
in. Okay.
Yes.
Okay. No, that's fine. That's okay. That's no problem, Zandile. So I'll just then invite Dr. Majola again. Dr. Majola, any more comments after Prof. John's advice?
I just want to ask John, on a practical note, when you do the bladder neck incision, where about do you actually make the incision, and how deep do you go, if that's a measurable incision per se?
Yes, I think you read in the books that they describe doing it at 8, 5, and 12 o'clock. You will be able to identify the valve. This is key, by not only seeing the sheet of tissue, because you can get confused with the sphincter, but by seeing what are called the plia caliculi. In other words, you've got the verumontanum, and coming out towards you from the verumontanum are these 2 folds that then become the valve. So that's the classic type 1 valve. Hugh Hampton Young described all those years ago. And I find your best bang for buck is, in fact, to turn the scope upside down, and then you're looking out from underneath in your loop. Maybe I think my video might be on, I don't know if you can see, but you're effectively, then you're looking out from below, and the cutting cautery is at the top. And then you get a lot of ability to quite nicely ablate the valve at 12 o'clock. And often these valves are not a thin sheet of tissue, it's often quite a thick tissue. The other thing to say is that you're safe going at 12 o'clock. There's nothing you can damage. Even if you go outside of the bladder neck area there, you can't do any major damage. It's going to heal nicely.
Okay.
I would want to add to that that you can run into a bit of trouble with the bladder neck incision, because that you can, in fact, undermine the bladder neck trigone area. So you've got to be a little bit cautious when you go deep there. But I would encourage you to feel safe going at 12 o'clock. And yes, you can go at 5 and 8, but I must say, mostly if you go at 12, you're going to effectively divide the valve in two, and it's going to be flapping in the wind, and you'll have done a good job.
Yeah.
Okay, thank you.
John, it's so very interesting, because these are the things which Larry G has taught. He has, I'm sure, written about those things, and this is almost like word to word description. What you are describing is that you turn the scope upside down and then incise the valve, and they are not very thin and flimsy. They actually are a bit of tissue, and it needs efforts to either ablate them or to cut them. So that's very good. Jandile, if I can ask you to just sort of clarify two concepts. The first concept is about urinary ascites. How will you manage urinary ascites in a newborn? That's number one. And secondly, just give us a little more information about Potter's syndrome. I know because of shortage of time you didn't elaborate, but you can start with, what do you mean by Potter's syndrome? Jandile? Hi, Jandile.
Yes, hello.
Yes. Did you hear
Can
my
you hear
question?
me? Yeah, yes, Prof. I had the question about Potter syndrome and the
Urinary ascites.
ascites.
Okay, so just talk about Potter syndrome for about a minute, and then talk about urinary management of urinary ascites in a newborn, obviously associated with posterior urethral valves, for 1 minute.
Okay. So it is a Potter's syndrome is caused by oligohydramnios, as I have mentioned, and
Sorry, Jandile, we are losing you. Hi, Jandile. Hi, Jandile. Is he still on? I think he's probably got disconnected. Um, just give him another second. Hi, Jandile, we have lost you. Okay, 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 no problem. Okay, okay. No, it looks like he's having trouble reconnecting. Um, yeah, I don't think we need to keep waiting, and especially keep Prof. John waiting. So I think, John, last few words from you before we close the meeting. I see him here.
Yes, Milind, just once again, thank you very much for the invitation. I would like to encourage the juniors to, they're going to choose one topic to start their reading with pediatric urology. I'd encourage them to read about valves because it has all the things that you find in other chapters, such as reflux. It's akin to the neuropathic bladder, avoiding dysfunction. So it's a good place to start your reading. And a fascinating illness, and these patients are often with you for a long period of time. So getting it right from the first go is important. Thank you very much, Milind.
Yes, thank you, John. And just so interesting that you know Paddy Devon much more than we do. But I have also I've met him and I've seen him operating live in Bloemfontein. So it's always so nice to see that somebody who is so prominent in the field of pediatric urology, we know that person, we have met that person, we have learned firsthand from that person. So, John, thank you very much for your contribution, and we will involve you again sometime next year.
Absolute pleasure. Thank you, Milind.
Okay, thank you, everybody. So, Zondile, if you can please email me your presentation, then I will put it on the Zoom group. And Mia, if you can just hang on for a few minutes, I just want to check if I can transfer the hosting rights to you. Hi, Mia. I think that
Yeah.
yeah, the rest of the attendees can disconnect or leave the meeting. Thank you very much for your attendance. Thank you to Dr. Jula for excellent presentation, and to Dr. Majola for guiding him, and for rest of the staff members to attend. And I am recording, so I will share the link as soon as I've recorded the meeting.